So thank you for coming today. I know you have a big test this week, so thank you for giving up your study time. But I hope you enjoy the lunch. And my name is Janine Morelli. I'm a family doctor in the Department of Family, Population, and Preventative Medicine. And I am the faculty facilitator for a student club that is called the Stony Brook Catholic Medical Student Physician Association. And today we have a guest lecture from San Diego, California, Dr. Delgado, who is a family doctor who continues to do prenatal care and is also a associate medical director of hospice. And you can see him here in the corner. His presentation will be about 40 minutes, and then there'll be an opportunity for questions and answers, but you'll have to come up to the podium to ask him your questions. Okay, so Dr. Delgado, I'll turn it over to you.
Great. Well, good afternoon, everybody, and I hope all your studying goes well and your finals certainly go well. Brings back good memories for me, and it's really wonderful to see so many people interested in abortion pill reversal, which is my topic today. First of all, I want to disclose that I have no financial ties or benefits of giving this lecture. I'm going to talk about the reversal of mifepristone with progesterone, something that's a novel concept that's brand new. And many physicians and residents have not heard of this, so you're really on the cutting edge of hearing about something that's very novel and new, and to me, very exciting. This is for women who have taken mifepristone, also known as RU46, and changed their minds. So they change their minds. They're wondering if there's any way they can reverse the effects of the mifepristone, and we discovered a way to help them. This is our APR team. I'm the medical director. Dr. Matthew Harrison is our associate medical director, and Dr. Mary Davenport is our director of research. Dr. Matthew Harrison was really the first to successfully reverse the effects of mifepristone back in 2006. And he had a woman who came into his practice who had taken mifepristone and asked him, is there any way I can reverse it? He had never read about this, knew it hadn't been done, but he reasoned, well, maybe I can give her progesterone because he had been familiar with progesterone, maybe I could reverse it. And in fact, it worked. And the baby survived, and she's now about 8 years old and doing very well. I had a very similar experience in about 2009. I had not heard of Dr. Harrison's case, and I was unaware of it. He didn't publicize it or write about it. When I got a call from a woman who has a pregnancy help hotline, and she had gotten a call from a patient in El Paso, Texas, who had taken mifepristone and wanted to reverse it. She had regretted her decision and was wondering if there's any way we could reverse it. So she called me, and I said, well, gosh, I've never heard or read about it, but I had studied mifepristone. I knew how mifepristone works. I knew that mifepristone is a progesterone receptor antagonist. And I had used a lot of progesterone in my practice for women who are at risk of miscarriage, something we call threatened SAV. And I knew that giving women progesterone, or giving women who had low progesterone, could prevent miscarriages. So I reasoned, well, if we gave lots of progesterone, we could outcompete the mifepristone at the receptor level, and perhaps then we could negate the effects of the mifepristone and save the baby. So I found a doctor in El Paso, Texas, Dr. Jonalyn Bellacura. She had progesterone in the office. She was willing to help. And I devised really a protocol there on the fly, and she agreed to try it. She did it, and the baby survived. So after that, I started getting calls from people around the country who were interested in this, and I started giving people advice on what our experience was. And pretty soon we had a case series, and we decided, well, we probably ought to write a case report about this. So we wrote a case report about a series of 6 patients, and we were published in the peer-reviewed journal called the Annals of Pharmacotherapy back at the end of 2012. So this is still the only case series report of reversal of the effects of mifepristone. We have another manuscript in process that I'll be talking to you about a little bit farther down the line. So this article can be accessed online, Annals of Pharmacotherapy. Let's talk a little bit about mifepristone. I told you it's a progesterone receptor antagonist. So it also can be considered a progesterone receptor modulator, or PRM. You've obviously heard of estrogen receptor modulators, certain drugs that affect estrogen receptors. And it blocks the effects of progesterone, which are, of course, are essential for a healthy pregnancy. So it binds to that receptor, but it does not cause the post-receptor effects, and so therefore it is an antagonist. And what are some of the effects of progesterone? Just to review a little bit your anatomy and physiology. We know that progesterone prepares the endometrium for the implantation of the embryo. That endometrium has to be thick and luxuriant for the embryo to implant successfully. It also promotes the decidual development. And if you remember from embryology, the decidual basalis is the very thin layer that comes from the endometrium, is where the chorion part of the placenta attaches. So it's really a very minor part of the placenta, but it's very important for that attachment, for the placenta to be well adhered to the endometrium. Progesterone also inhibits myometrial contractions, because of course during pregnancy you want the uterus to be nice and relaxed, you want it to be pliable so it stretches out as the baby grows. At the end of the pregnancy, what happens? Progesterone levels fall, and then you start to have contractions. The progesterone also promotes the development of milk-producing cells in the breast, but at the same time, it also inhibits milk production. So of course, a very clever design, because you don't want milk produced during pregnancy, but at birth, you want the breast ready to go. And this is why, of course, during the first trimester, women get large, tender breasts, because that's under the effect of progesterone. And finally, the progesterone helps keep that biological valve, the cervix, closed, because during pregnancy, the outside world should be totally separate from the inside world of the uterus. And of course, at the end of the pregnancy, when progesterone levels naturally fall, what happens? The cervix starts to dilate. So those are the actions of progesterone. So we know then that if you block all those actions, well, what's going to happen? First of all, the most deleterious thing to the embryo, and what causes the abortion effect of mifepristone, is that effect on the decidual basalis. You get separation of the chorion and the decidual basalis, essentially separation of the placenta from the uterus, and you don't get good blood flow to the placenta, the embryo dies. So it's really a toxic effect on the placenta that leads to the embryocidal effect of mifepristone. The other things that happen, of course, are important for the completion of the abortion, and that is that the myometrium is no longer inhibited from contracting, so that the myometrium can start to contract. And the cervix starts to soften and starts to open, starts to dilate, so that the contents of the uterus then will be passed with the completion of the abortion. Now, let me back up here. We know that the mifepristone is very effective at causing the separation of the placenta. However, it doesn't always cause vigorous uterine contractions. And so because of that, a second drug was added to the cocktail, misoprostol, which I'll talk about in a few minutes. So a little bit about the development of mifepristone, also known as RU486. The French drug company Roussel Uclaf developed the molecule back in the 80s. And it was labeled RU 38,486 because that's the way drug companies label their medications. They don't give them a proper name while the drug is in development, because as you may know, probably only about 10% of drugs that they actually study and develop will actually come to the market. So usually give it a sequential, a serial number, if you will, with often the name of the company being represented in the initials, in this case RU. So if you had a GlaxoSmithKline producing a drug, they might call it GSK 10,552. Well, it became RU 38,486. That's kind of long and cumbersome, so when they saw that it had some promise, what did they do? They shortened it to RU486. Because this was such a controversial drug from the very beginning, people heard about the name RU486, and still it's come up in the common vernacular. Many other drugs have these labels, but no one ever knows about them because they're not controversial and they're not on the news prior to approval. The generic name, of course, is mifepristone. The brand name in the United States is Mifeprex and Mifegon in Europe. And so eventually Roussel Uclaf got bought by a German company, eventually merged with several other pharmaceuticals, and it's now part of Sanofi. However, the mifepristone product was sold off because Roussel Uclaf did not want to market it. And so in the United States, Danco Laboratories bought the rights to it, and that's their sole drug that they produce. They do that as a strategy to avoid litigation, to avoid boycotts. In the United States, mifepristone has been available since the year 2000. By 2008, a quarter of all U.S. abortions prior to 9 weeks were accomplished with mifepristone. Today, about 20%, depending on what you read, 18 to 25% of all abortions at various gestational ages. So all abortions, about 20% are performed with mifepristone in the United States. In some European countries, that's up to 80%. Where really, it's been eclipsing the surgical abortions. Mifepristone is followed 2 days later by the second drug I mentioned before, misoprostol, also known as Cytotec. Misoprostol is a prostaglandin analog. Any of you who've done your OB rotations or been reading about OB know that various prostaglandins can cause uterine contractions. We use prostaglandins to ripen the cervix in a woman we're trying to induce. Also for women who have had a fetal demise, and let's say it's before 32 weeks when there aren't very many oxytocin receptors in the uterus, we will give a prostaglandin analog such as misoprostol in order to cause the delivery of the remains of the baby. Off-label use is up to 63 days after the last menstrual period. That's 9 weeks gestation for mifepristone. The FDA-approved protocol is to use it up to 49 days after the LMP or 7 weeks gestation. On day 1, mifepristone is given at 600 milligrams orally. On day 3, misoprostol or Cytotec is given 400 micrograms orally. And on day 14, the protocol specifies that there should be confirmation of embryonic demise. As you know, many drugs are used off-label. This is no different. And the off-label protocol, which is really the protocol that's most commonly used now, has the drug being given up to 63 days after LMP, like I said before, 9 weeks of gestation. On day 1, mifepristone, 200 milligrams is given. Why did they go down on the dose to 200 milligrams? Well, 2 reasons. One is that mifepristone is a very expensive drug. Number 2, various studies have shown that in the range from 100 to 600 milligrams, there's no difference in the effect. So 100 is as good as 600. So they chose 200, and so now there's a 200 milligram pill. That's really the standard dose being given right now, for the most part, 200 milligrams given. Now the misoprostol Cytotec, the dose was increased for that on the off-label protocol to enhance the uterine contraction effect, and that's now 800 micrograms given, which is 4 tablets, which are 200 micrograms each. Now, because when you take the misoprostol Cytotec orally, it causes a lot of nausea, diarrhea, and other side effects, the misoprostol is now generally given either sublingually or buccally between the cheek and gum, or vaginally, and that's to cause direct absorption and to avoid some of the GI side effects. And that's generally given between 24 and 48 hours after the mifepristone. So the mifepristone first, 200 milligrams, 24 to 48 hours later, the misoprostol to cause the contractions and emptying of the remains of the embryo. So let's look at some of the efficacy trials that the FDA ran. And Dr. Spitz was one of the primary researchers from this. These are articles that are published in the New England Journal of Medicine. The rates of incomplete abortion were 5% before 7 weeks of gestation and 7 to 8% at 50 to 63 days, up to 9 weeks. Now, it's important to remember, because this has been confused and probably misrepresented, and we'll talk about this a little later in more depth, is that incomplete abortion means that the uterus did not completely empty. Incomplete abortion does not imply that the embryo did not survive. So this is a very important point that I want you to keep in mind. The rates of surviving embryos are less than 1% before 49 days and 9% if given at 57 to 63 days. Okay? So these are the FDA trials using mifepristone and misoprostol. Now, how about the efficacy of mifepristone only? We have to go back to the older studies for that because, like I said early on, they switched over, started using the 2-drug cocktail because the mifepristone had a higher rate of incomplete abortion rate. So the complete abortion rate, where everything was emptying out of the uterus with mifepristone only, the studies show it to be 60 to 80%. That, of course, the corollary is the incomplete abortion rate of 20 to 40%. However, when you look at embryo survival rate, then you find that the embryo survival rate with mifepristone only is only 7 to 20%. Okay, so very important to keep that in mind. Embryo survival rate, mifepristone only, 7 to 20%. And we'll be publishing a review article. We review the literature on the mifepristone only studies. We're going to be publishing that, so that's very clear. For those of you who are interested in molecular structure, here's the structure of mifepristone compared to progesterone. So somewhat similar. You can see how it could work as a progesterone receptor modulator. Let's talk about some of the physiology and pharmacology. Well, first of all, it was actually first developed in studies for its anti-glucocorticoid properties because it binds to the glucocorticoid receptor 4 times as avidly as dexamethasone. So that's very important. It's also studied for treatment of endometriosis, uterine fibroids, and it was even considered as a contraceptive. It actually could work as a contraceptive. It would probably be very expensive and might have some other problems with it. It has actually been, mifepristone has been approved for the treatment of hyperglycemia and Cushing syndrome. Korlym, K-O-R-L-Y-M, is the brand name associated for that. And they wanted to have really a very distinct branding. Just like, for example, you have distinct branding for bupropion, you have Zyban for tobacco cessation, while you have Wellbutrin for depression. Same sort of thing here, except the pill size is different. It's available as a 300 milligram pill, while the Mifeprix is available as a 200 milligram pill. The dose for Cushing syndrome is 300 to 1200 milligrams per day, maximum 20 milligrams per kilogram per day. And again, by blocking the glucocorticoid receptor, then all the excess glucocorticoid activity can be dampened. Let's look a little bit at the pharmacology and the pharmacokinetics. 70% of it is absorbed orally, so pretty high oral absorption rate. After it goes to the liver, first pass effect, 40% is available. It binds to the progesterone receptor twice as well as progesterone. That's very important to keep in mind. And it attaches to the alpha-1 acid glycoprotein in the serum. Demethylation and hydroxylation catalyzed by the cytochrome P450 enzyme 3A4. 3 metabolites retain biologic activity. The serum half-life is 18 to 25 hours. Progesterone's half-life is about 25 hours. The metabolites, however, can be measured in the blood up to 72 hours after a dose and maybe even beyond. So they hang around for a while, and those are active metabolites. The progesterone receptor, for those interested in receptor biology, is a member of the nuclear receptor superfamily. A lot of related receptors, including the androgen receptor, the estrogen receptor, and the glucocorticoid and mineralocorticoid receptors. And there are different isoforms. The alpha and the beta can be promoters and suppressors. When I give this talk to lay audiences, I talk to them about how the receptor and the molecule can fit like a hand fitting in a glove, or also like a key going into a lock. And you've probably studied the lock and key hypothesis. Well, the key going into the lock that turns the lock is the actual hormone. They call it, and the hormone effect is the opening of the doors. That's the analogy. However, if you have a false key, a key that fits into the lock but doesn't open a door, that's a receptor blocker or an antagonist. That's the false key that mifepristone is. It blocks the receptor. It doesn't allow the door to open, so no hormone effect. However, we know that hormones and analogs go off and on receptors. It's a dynamic thing. So we can imagine the mifepristone going into that the keyhole and staying in there twice as long as the progesterone stays, but it does come out eventually. So if you have more progesterone keys around the lock, they can outcompete that mifepristone key, even though they don't stay in there as long. And so that's the rationale, the biological rationale for this. If we look at a schematic of the receptors, you can see above the agonist in blue, the little blue dot, connecting to PR. PR is progesterone receptor. There may be co-activators that help it along the way, and that then leads to DNA transcription, producing the messenger RNA. The messenger RNA then moves outside of the nucleus and becomes translated into the protein products, which then lead to the hormone effect. However, on the bottom you see the red square, which is the antagonist. It'll bind perhaps to another part of the receptor or to another isoform of the receptor, PR, the progesterone receptor. But that blocks the whole process, so you do not get any transcription of the DNA into RNA, so everything is stopped. You get no hormone effect. All right, let's now shift gears a little bit and look at the patients in our first published series that I mentioned earlier in the Annals of Pharmacotherapy. So we had 6 patients. Their gestational ages range from 7 weeks to 11 weeks at the time they received the mifepristone. As you can see, the one at 11 weeks, that was given outside of the usual off-label protocol. But we have seen that in other cases where women have called us and have told us when they've taken the mifepristone. The second column shows the interval to progesterone, how long it took for them to get progesterone on board, and it was from 7 hours to 72 hours. The third column shows the first dose of progesterone, what it was. You can see that all but one got progesterone intramuscular injection, 200 milligrams. One got progesterone per vagina, That was progesterone oral capsules given per vagina. We later got progesterone IM. And the outcomes were 4 healthy newborn babies with no birth defects, with no complications at all, and 2 completed abortions. So this showed us that we thought, well, we were onto something and we were going to move forward. Now, a couple of issues that came up, though, as this started unfolding before us. I realized that there were 2 problems that we had. Number one was that time was of the essence. We needed to get the progesterone on board very quickly. And so to do that, we needed doctors in every area of the country who could help these women, because we were getting calls from women all over the country. Secondly, we needed an easy way for women to find out about this, because if women change their mind, they should have the right to know that there's a way to reverse this, and also an easy way to contact us. So we set up the abortion pill reversal program at that point, including a 24/7 hotline, a website, and a network of physicians across the country. So that put in an infrastructure in place so that we could help these women and provide them excellent medical care with physicians who are very competent and very willing to treat them. So these are statistics from May 2012 to November 2015. We've had greater than 1,200 calls to our hotline. We've had 143 babies born, and currently we have 85 who are pregnant. The success rate has been 53%. As we've been measuring this throughout the time, the rate has ranged anywhere from 53% up to 60%. So low to mid-50s most of the time. How about birth defects? We've had 2 birth defects. One has been a porcine stain, which is a vascular marking on the face. The other was an infant who had some missing digits. Now, when we calculate the birth defect rate, overall it's 0.87%, which is very much less than the rate that's quoted for the general population for major birth defects. And that quoted rate is usually 2 to 3%. Some authors will say as much as 5%. So we'll say 2 to 5% is what we expect in the general population, and we have about 1%. So we're very happy with that. This out now actually is the largest case series of women exposed to mifepristone and looking at the birth defects. We'll look at another study later. We've helped women in 45 states so far, and in 17 foreign countries. So helping women in a lot of different areas. In Australia, they've established their own abortion pill reversal hotline, and that makes sense because with all the time zone differences, it makes sense for them to have a regional. And we have some doctors and others in Europe who are interested in establishing their own regional hotlines there. But in the meantime, we'll take calls from wherever they come to help them. So let's look at some challenges and barriers to all of this. So the first one I mentioned already, birth defects. People are very, very worried about birth defects. And women who have taken mifepristone and changed their minds, even though they now want to save their babies, they are very, very interested in the risk of birth defects and very concerned about it. So it's a very legitimate concern, so we need to address that. When we look at the data for birth defects for mifepristone on the left, misoprostol on the right, and when they've taken both drugs together in the middle, we have a lot of data for misoprostol, fair amount of data for both, not a lot of data for those who've only taken mifepristone. But when we look at what we have, we can see the conclusions are that with mifepristone, there are no good data suggesting that there are birth defects in women who take mifepristone only. The women who take misoprostol only, they do have birth defects, probably in the range of anywhere from 3 to 12%. And those birth defects are limb reductions and facial paralysis and something called the Mobius syndrome, which I'll discuss in a minute. Now, when you look at women who've been exposed to both mifepristone and misoprostol during pregnancy, we find that the birth defects are exactly the same for the most part as those who were just exposed to misoprostol. So our conclusion is mifepristone is not causing those birth defects, that it's the misoprostol, which is known to cause birth defects. Let's talk about the Mobius syndrome that I mentioned. This is a syndrome that's associated with misoprostol. It's associated with unilateral or bilateral palsy of the 6th cranial nerve and the 7th cranial nerve, and other cranial nerves being involved. There also may be craniofacial or orofacial abnormalities, and sometimes limb malformations, arms and legs. The etiology is really unknown, but it's clear that the critical period appears to be between 5 and 8 weeks gestational age. That, of course, is about the time when women are exposed to misoprostol when they're attempting a medical-induced abortion. And like I said, to date, mifepristone does not appear to have induced the Mobius syndrome. When we look at some of the authoritative textbooks, there's one called Drugs in Pregnancy and Lactation, and they list mifepristone as being teratogenic in rabbits, causing deep birth defects in rabbits, no teratogenesis in monkeys and rats, and they feel the human data are insufficient. In March of 2014, about going almost on 2 years ago, the American College of Obstetricians and Gynecologists put out a practice bulletin that stated that there's no evidence that mifepristone is teratogenic. So there we have it. And ACOG is not a disinterested party. They actually have been very critical of our efforts to reverse mifepristone. And so the fact that they come out with this statement, I think we can trust what they're saying, that the data are supportive of mifepristone not being teratogenic. Aside from our series, there was another series in the British Journal of OBGYN back in 2013 that was an observational study watching women whose babies had survived mifepristone only or mifepristone and misoprostol. This was a total of 105 pregnancies, and they found that the rates of major malformations were only slightly higher than the expected 2 to 3% rate, and they felt that this was reassuring for the risk evaluation for continuation of pregnancy after mifepristone exposure. So that was reassuring. We have many more studies for misoprostol-only exposure, and so if we look at this study back in 2013, the odds ratio of birth defects was 2.2. In other words, compared to the general population, there was a doubling of the birth defect risk in women who would have been exposed to misoprostol. Another study out of Argentina, the risk ratio was 2.27, so about 2.25 times the general population. Finally, another study showed an odds ratio of 3.5 times, so 3.5 times in chance of birth defects compared to the regular population. This was an interesting study from France, where they had a teratogenesis center, and there were 71 failed medical abortions. And so these women were very worried, so they called this hotline to ask about the risk of birth defects, and so they gathered the data. And out of 71 failed abortions, 8 of them turned out to have birth defects. So a little over 10%, maybe 12%. Of those 8 cases of birth defects, only 1 of them had been exposed to mifepristone only. The other ones had been exposed to mifepristone and gimiprost, which is a drug similar to misoprostol. So that's reassuring. How about progesterone safety? We're always interested in progesterone safety. Well, an article in the Archives of Pediatrics looked at babies with hypospadias and compared those to groups of babies who did not have hypospadias. Hypospadias is a birth defect of the penis that is correctable. The mothers of those with hypospadias were more likely to have taken a progestin. Progestin is a category of molecules that have progesterone-like effects, but it can include drugs such as medroxyprogesterone, also known as Provera, that actually are known to cause hypospadias. Here they didn't delineate which kind of progestin the mother had taken. So we know that with progestins overall there's a risk of hypospadias. However, in 1999, the FDA previously come out with a review stating that they felt that there was no risk of birth defects, including hypospadias, in pregnant women who took progesterone or 17-hydroxyprogesterone capivarate. 17-hydroxyprogesterone is FDA approved to be given to women throughout pregnancy to prevent preterm birth, and it's given to women who've had a history of preterm delivery. Dr. Thomas Hilgers is in a group in Omaha, Nebraska, who have been studying a lot the uses of progesterone in pregnancy, so they've had a great experience with it and keeping very good statistics. The women who took progesterone, the risk of hypospadias was 1 in 1,000 compared to the general population. The risk in pregnant women is 1 in 250. So actually in their group, they had a lower rate of hypospadias compared to the general population. So that's very reassuring. And a disinterested group called the American Society of Reproductive Medicine. These are the IVF doctors. Their main concern, of course, is having their test tube IVF babies survive and to delivery. So they almost routinely give progesterone throughout the first trimester. And their statement is that the long-term adverse consequences of progesterone therapy have not been identified in humans and appear unlikely. So they feel very comfortable, and in fact their actions support that. The IVF doctors use progesterone just about every pregnancy. Some other challenges to us is finding a doctor. We touched on that. We need to have a doctor in every area to help these women, and our network is growing. Sometimes doctors don't have progesterone in the office, and that can be a problem. There's been opposition from medical establishment and others. They contradict themselves by saying that reversal is unlikely and that mifepristone is ineffective. So why would you give mifepristone if it's ineffective in the first place? They really exaggerate the failure rate. Remember, I told you that mifepristone leads to incomplete abortion 20 to 40% of the time, and that incomplete abortion means that the uterus is not completely empty and does not imply embryo survival. In the early mifepristone-only studies, when you look at those very carefully, you look at the ones that really look to see if embryos survive, not just if the uterus was completely empty, we saw that the embryo survival rate was 7 to 20%. Then these women went on to have surgical abortions, so we really don't know which ones would have survived to birth. There have been charges against us that this is junk science. Well, I don't think it's junk science, it's new science. And it's new science, something that's new. This doesn't mean it's bad science, it just means that it's a new concept. And I think there's a lot of scientific rationale. First of all, there's biological logic, because we know the mechanism of the action of mifepristone and progesterone. We know they compete for the progesterone receptor. So it makes sense that one could outcompete the other if its concentration were higher. There are basic studies in Japan, basic science studies on rats that showed that a group of pregnant rats given mifepristone only, and another group of rats given mifepristone plus progesterone. The group that got the mifepristone plus progesterone did not have any of the mifepristone effects. So the progesterone definitely reversed the effects of the mifepristone in those rats. And of course, like I said, we know that the mifepristone, that the baby may survive 70 to 20% of the time. Our success rate of 53 to 55 to 60% is much better than the 70 to 20% survival rate. So I think that makes sense to offer this to women who change their minds. They've been critical of us using progesterone off-label. Of course, that's very hypocritical because they use the mifepristone protocol they use is off-label itself. And off-label use of medications is readily accepted and practiced in the country. And the off-label use of progesterone is no different. And we also know that another progesterone product, 17-hydroxyprogesterone, is approved in pregnancy. So the safety is there. It's okay to use it off-label. It follows traditional medical practice and guidelines. And some of their articles and critiques have been that women never change their minds. Well, we know that people can and do change their minds. People change their minds all the time about important decisions in life. So I think it's really ridiculous to say that they don't change their minds. And the studies that they quote on women who are interviewed right after having usually surgical abortions show that about 10% have ambivalence or second thoughts. Other studies that actually follow women for a longer period of time so they can kind of get past that initial denial and rationalization stage shows that much higher percentage of women end up regretting their abortions. Several studies by Dr. Priscilla Coleman and others have shown that. So the question we have for our critics is, why would you deny a woman a second chance? If a woman wants to reverse it, why not give her that opportunity? Why not give her a second chance at choice? So our conclusions are that mifepristone reversal using progesterone is safe and effective. Our growing case studies show that the effects of mifepristone can be stopped by the administration of progesterone. Our goal is to outcompete the mifepristone at the receptor level. There's no significant evidence suggesting that mifepristone or progesterone cause birth defects. And progesterone and 17-hydroxyprogesterone caprate are safe in pregnancy. So we're considering a protocol. This is what we consider that the molecular weight of progesterone is 314, while that of mifepristone is 429. Pretty similar. Half-lives are pretty similar. And that the metabolites are in the blood at least 72 hours out. The mifepristone binds about twice as avidly as the progesterone. So it seemed that if we could get about twice the dose of progesterone in there, then we'd have a fair chance of outcompeting. Well, 200 milligrams iron is kind of the highest dose of progesterone that's typically used. But the good thing is that the mifepristone, only about 40% is available after the first pass effect. So that kind of evens the playing field. So you have about 200 milligrams of progesterone, 100 milligrams of mifepristone available, and the mifepristone binds twice as well. So pretty equal playing field there for competition. So protocol we devised is to give 200 milligrams intramuscularly as soon as possible after the ingestion of mifepristone, preferably within the first 24 hours, but certainly up to 72 hours out. And perform a transvaginal or transabdominal ultrasound as soon as possible because we want to confirm if the baby's still alive. If the embryo has already died, there's no use to give the progesterone. However, if ultrasound is not readily available, we recommend getting the progesterone on board and then looking to find the ultrasound so we don't delay. And one extra dose of progesterone isn't going to hurt the woman. If the embryo is less than 6.5 weeks gestation, you might consider HCG levels, but they have to be interpreted cautiously because HCG is produced by the placenta, by the chorion, and so the chorion is stunned, it may not produce the right levels of HCG, so that can be misinterpreted even if the embryo eventually survives. Then we'll repeat the progesterone once a day for 2 more days, then every other day until day 14 after the ingestion of mifepristone. That's to cover that 72 hours, and then out until day 14 to allow placental recovery. And then we treat twice a week until the end of the first trimester because we know that the placenta normally is kind of kicking up progesterone production up until the end of the first trimester when it's really kind of on its own. Some women refuse intramuscular injections. Some physicians don't have the progesterone in oil. The 17-hydroxyprogesterone is very expensive, and we don't want to use medroxyprogesterone acetate because it can cause birth defects. So we have alternative protocols in these cases, and that would be progesterone compounded vaginal suppositories, 400 milligrams, self-administered every night until the end of the first trimester. Compounded vaginal suppositories can be difficult to get, but not that difficult. Off-the-shelf progesterone, brand name Prometrium, 200 milligram oral capsules, 2 capsules self-administered vaginal each night until the end of the first trimester. Or those same capsules taken orally, 2 at night, or even 2 twice a day until the end of the first trimester. And we've seen good success with that. Currently, we're analyzing our data, preparing a second article, and that should shed light on the relative efficacy of using vaginal versus oral versus intramuscular progesterone, and we'll have some recommendations when we're finished with that. Some clinicians monitor progesterone levels after the first trimester and administer progesterone if the levels are still low after the first trimester. So it's important that doctors prepare for the protocol and have progesterone on hand, either compounded or off the shelf. The off the shelf is easier to get, but it's a higher volume injection, so there are pluses and minuses. If they go with compounding pharmacies, they should find one that's trusted, and there are trade organizations that can lead them in the right direction. 2 pharmacies we've used have been Kubot Pharmacy in Omaha and Central Coast Pharmacy out on the West Coast that do a very good job, a very high-quality product. Proper technique is critical. The injection can be uncomfortable if it's not given correctly. It needs to be given very high and lateral, not in the mid-gluteus, but up in the high lateral gluteus. The progesterone should be warmed to room temperature. It should be given by the clock very slowly over about 2 minutes. It's important for offices to be available to help these women. How do they find us? Usually they go to abortionpillreversal.com. Then they call our hotline, which is 24/7 staffed by nurses. This is our website, abortionpillreversal.com. If you're interested, I welcome you to visit. A lot of good information on there. And we have over 300 APR doctors now, probably greater than 350 at last count. We've held this press conference at the National Press Club. A lot of media exposure after that, many national publications, including the Washington Post, New York Times, Canadian Broadcasting Corporation, National Public Radio. This is our APR kit, which is a nice kit for offices to have. It has all the protocols, consent forms inside there. It also has a place to store progesterone and syringes and needles so that this can be on the shelf. When the patient comes in, the office knows exactly where it is. They've looked at it, they've studied it, they know exactly what to do. We have a 4-pronged approach for recruitment: primary care doctors, OBGYNs, emergency doctors, and licensed pregnancy medical clinics. This is our website, and if you want more information, you can contact our executive director, Sarah Littlefield, at apreversal@gmail.com. Now we've talked about numbers, and I want to talk a little bit about the faces behind the numbers so you can see the personal stories, and then we'll leave some time for questions. This is a text message from a satisfied patient. Hello, Liz, I just got home. Yes, I got the shot, and I'm going to return tomorrow. Also, I just wanted to say thank you from the bottom of my heart. You really saved me. I knew I had done wrong. It was by chance I got your number, and I'm so glad I did. I feel relieved. You are my saving grace. God bless you, Liz. If you count all the exclamation points in there, you can see how entirely satisfied this patient was who was helped by the abortion pill reversal program. This is a thank you I got from the first woman I helped in El Paso, Texas, and there's her baby right there who's now about 6 years old. More of the challenges and barriers. Sometimes there's lack of emotional support. Some families want them to abort. Some may be kicked out of their homes if they choose to reverse. The boyfriends or husbands often abandon them or are already absent. Many lack financial resource pressures. Women told us about abortion clinic pressures. One woman thought she was just going in for a consultation. She said before she knew it, she was given a pill and a glass of water and told to swallow. Numerous patients have called the abortion clinics when they changed their minds. And they told us that often they're told you have to, quote, finish what you had started. Many have been told there's no chance of reversal. So obviously the people at the abortion clinics are not reading the medical literature. They're also telling them that your baby is sure to have a birth defects. Again, they're not up to date on the medical literature. Antidepressant does not associate with birth defects. One sad case where a woman told us that she was told by the abortion clinic worker that if you try to reverse this, it'll be like shooting your dog and watching it die slowly. So we've seen a relative lack of compassion. Sometimes women change their minds. This was the case of Cynthia, my first San Diego patient, who was 19, a college student, and she decided to reverse the effects of the mifepristone. And there's her son and her now husband, who's the father of the child, playing in a park. So a great success story there. Now I want to share with you a video clip that appeared in North Carolina.
Doctors having a new treatment that she says can reverse the abortion pill and save the life of the fetus.
CBS 19 Stefan Dingle spoke with a doctor and a pregnant woman who wanted to end her pregnancy and then reconsider. So it just seemed like if there was any inopportune time for me to get pregnant, this was it. Okay. Can you mark up?
What's up, Becky? Crystal West is a mother of 6, and adding another child wasn't necessarily her plans. So she decided to end the pregnancy using the so-called abortion pill. It's a 2-step process, and after step 1, she had second thoughts.
When it comes to the medical field, where there's a will, there's always a way. And so I Google searched, if there was any possible treatment for undoing what I'd already done. It was too late. I couldn't throw the pill up. I couldn't get it out of my system.
No matter where you come from politically on the issue, these women are in crisis and are struggling. Sometimes people will make a decision and then they walk out of the room and in the light of day go, wow, I didn't mean to do this.
Less than a couple of hours after taking the pill, Crystal began to regret her decision as she came across this website, abortionpillreversal.com, which has a hotline of available nurses that connects her with local doctor Karen Pujedas.
We were able to see her and get the first progesterone shot into her about 25 hours after she had taken the pill, which was wonderful because the earlier you start, the better. It's very time sensitive. We have to fight the other medication. So this is a vial of the progesterone that we use in this protocol. The mifepristone doesn't directly attack the baby. So if we can give enough progesterone to keep the drug from getting to the receptors, if we can keep the placenta alive, there have been no cases of birth defects in the babies who have been born using this regimen.
Crystal had to wait 2 long days praying to find out if the baby had a heartbeat.
You can do nothing but sit there and think about it. That's all you do is you think. And you wonder, and you worry, and you stress.
Finally, on that Monday, she received an ultrasound at UVA Medical Center.
Absolutely amazing.
You can't feel that? No, you can't feel that.
I cried. I wasn't really thinking, There's no thoughts about that. It's relief. It was the biggest flood of relief that I've probably ever felt.
You're doing a great job growing up. Mine is not growing up. You are doing a great job. Make it. And you're still smiling while growing up. It's all good.
The chances of a baby surviving this procedure is 60-40. Crystal says she's glad she took the risk.
Well, what if your baby has birth defects? It's possible, but my baby will be alive. And that's a choice that I made. I don't feel like it was my place to decide whether or not the baby had a right to live.
Stefan Dingle, CBS 19 News.
Okay, so mifepristone reversal by the use of progesterone is safe and effective. It's growing. We have more doctors who are interested in it. It's a novel use of progesterone. It's the way to help women who have changed their minds after taking mifepristone and want a second chance at choice. And we know that some women do change their minds, and this is a way to help them try to achieve their dreams. Now we can have some time for questions.
You need to come to the podium to come talk in the microphone. We have 2 questions. I'll just come to the front.
Hi, Doctor. Thank you for your presentation. I just wondered if you would be willing to comment. I saw in one of your, sorry, I'm looking at you down here because I can see this screen. I'm not really sure where the camera is. But so I wondered if you would be willing to respond. You mentioned in your data that the rate of survival for patients who take the initial course of mifepristone, but then who don't continue on with the abortion procedure is as little as 7%. And I just wondered if you would respond to the data presented by the American Congress of Obstetricians and Gynecologists Arizona section that say that because medication abortion requires a combination of medications, in 30 to 50% of women who have taken mifepristone alone, the pregnancy would continue, which would seem to suggest that with an efficacy rate, I believe you mentioned in your sample size of 53%, that it seems like there's at least a potential here in some contrasting data for a placebo effect, insofar as progesterone maybe doesn't have any greater effect, at least in terms of other people's data, versus injection with progesterone versus just simply leaving the pregnancy at mifepristone. I just wondered where your low effective rate of 7% came from in contrast to the data.
Well, our rate that we're quoting, 7 to 20%, comes from the literature. And we did a very careful analysis of the literature. And what they're quoting are the incomplete abortion rates, 20 to 40%. This 50%, we have not found that 50% figure after carefully scouring the literature. Someone stated that and misquoted the literature, and that's been repeated over and over. So that 50% is definitely wrong. The 20 to 40% survival rate is a misrepresentation of the quote, continuing pregnancy rate. And in those studies, what they use, they define continuous pregnancy by defining it as content still in the uterus. But the studies where they looked and they determined that either HCG levels were still rising or where they could see an embryonic heartbeat, when you look at those studies, you find that the survival rate is only 7 to 20%. So those people in Arizona and others, there have been others who have used the exact same argument. They have misrepresented the literature, either misinterpreted it, which is possible, they're making a mistake, or they're misrepresenting it so to advance their cause. And so, and like I said, we have a manuscript we're preparing right now. It's a formal review of the literature, but anybody can go look at the articles now. They're there for anybody to look at, to honestly look at and to see that the studies that showed embryonic survival, they tracked that, and some of them did, that those show that the embryonic survival rate is only 7 to 20% in women who only got mifepristone. So that's where we get our data from the literature. And again, they're misrepresenting the literature, and that's where they've gotten your talking points. Does that make sense?
Yes, it does. I just wonder if you have time for one more question. There's obviously been a lot of political debate regarding this specific issue. I just wondered if you would respond to, so many of us in the room here are first-year medical students, and we just attended a seminar about evidence-based medicine. And in the pyramid of evidence-based medicine, what we were taught to hold as the gold standard were things like randomized controlled trials. And I just wondered if you'd respond to the reaction, the political reaction of some states like Arizona, that it seems like, all this data, notwithstanding, there's, taking this in a macro view, there's been a case report of 6 patients and a building case report of an N of around 1,200, which doesn't seem to me to read, this is just my personal read on it, doesn't seem to me to read like a randomized controlled trial. So I just wondered if you would respond to the influence that doctors might have on, even in a case report such as this, what responsibility do we have as physicians to say to lawmakers, maybe before these things are pressed into law, are put in the books, and the doctor-patient interaction is directly influenced by the law, e.g. in Arizona, where physicians are now mandated to state to women who are having an abortion via chemical means. I'm setting aside here the issue that maybe these women just aren't receiving good counseling before they make this decision, but that's a whole separate thing. I just wondered, would you respond to the effect of, with now an N of a maximum of 1,206 people, how would you respond to lawmakers using the evidence that's here now to influence the doctor-patient relationship by way of actual legislation?
Sure, yeah, that's a great question. I think it's something definitely to think about. The way I look at it is this. I agree, and I'm a big proponent of evidence-based medicine. We have to have evidence for everything we do. However, when you look at the big picture of medicine, there are very many things, and those of you in practice or those of you who are studying medicine will find that many of the things that we do in practice every day are not evidence-based. There certainly are evidence-based foundations, but as we get farther from that, we use a lot of judgment and a lot of analogy. Now, in this situation, there are 3 reasons why we shouldn't wait for randomized clinical trials to act. Okay? So, number 1 is that it's a life and death situation for the embryo. Okay? So, it's either life or death. So, if there's a treatment that's available, we should offer it. Number 2, these women who change their minds, they ought to have the right to know that there is something available for them if they choose to reverse the effects of it. And number 3, there is no alternative treatment. So if there were an alternative treatment available to reverse the mifepristone, and it was well studied, and of course we would favor that. Right now there's no alternative. So we go with what we have, and like I said before, this is new science, and if it's safe and it appears to be effective, I think we should go ahead and use it. And I think that women have the right to know about the possibility of reversal. Now, how they know about it, I think that's up to different groups in different areas, different states. I think certainly the best way to inform it is to have very strong educational campaigns. But you see that anecdotally from the women who've come through our network and have called us, they're getting almost uniformly misinformation at the abortion centers. They're not told that there's a chance of reversal. They're actually being told that it could be harmful, that they're sure to have birth defects. And so they're getting all this misinformation. So I think the state of Arizona decided that they needed to do something, and that's why they felt it was right to pass this law. I think having a law like that is probably should be the last resort. When you mandate something like that, I agree with mandating physicians to do something. However, in that state, they felt that the abortion clinics were just not being responsive. And that's been our experience, too, that they are sort of biased and categorically opposed to a woman having a second choice.
Thank you. I know other students have questions.
I just have a question about, because your research is not evidence-based, or the research that's been published, do you feel, and it's been pretty much universally rejected by the American Congress of ACOG, do you feel like it's your responsibility to let your patients know that this treatment is experimental and not evidence-based when they come in to see you? Because I didn't see that anywhere on the website.
Yeah, well, it's true that ACOG has rejected it in most, but we have to remember that ACOG almost universally is pro-choice and not pro-life. When you look at another respected professional organization called the APLOG, the American Association of Pro-Life OBGYNs, they actually have endorsed this. So it's important to keep that in perspective. What we do, and our consent forms actually, our consent forms up to now have said that this is an experimental treatment. So we do let the women know that we don't have tons and tons of evidence that this is new and novel. At this point, though, I think with the growing case series that we have accumulating, I think we are transitioning from this being experimental to now really this should be characterized as a novel treatment. That you're right, and we don't claim that we have any randomized controlled trials, because we don't, but there is evidence behind it, and while the gold standard is randomized controlled trials, that does not negate the effect of other research and other data. So we have to keep that in mind, is that, like I said before, lots of what we do in medicine is based on less than grade A evidence and less than randomized controlled trials. So let's keep it in perspective, and be honest about that. Yes, this is a novel treatment. Up until now being experimental, now being more accepted, more experienced with it. It is safe, and the evidence we have now is that it is effective. And yes, we don't have randomized controlled trials, but we work with what we have, and we present that to women, and it's their choice whether they want to do that or not.
So the answer is no, you don't feel a responsibility to publish it on your website then? I just want to make sure I'm understanding.
Well, on our website to say that it's no, because we have that in our consent form, and so those are the women who are actually who are going to be making that decision.
Okay.
So they're informed.
So do we have time for one? Hi, I just had one question, also related to evidence-based medicine. I was wondering how you chose the original 7 women for your first case study. I couldn't access your paper, but I did read a review. And the review says, it appears that in at least 5 cases, a living embryo was documented prior to initiating progesterone treatment. And if you were already checking for a living embryo before beginning the treatment, wouldn't that cloud your conclusions?
Yeah, that's a very good point, and that's a potential confounding variable. However, just to get to the first part of your question, we didn't choose those 7. They came to us, and those are just the first ones they accumulated. So there was no cherry picking of cases, if that's what you're implying. But as our case series has grown, there have been many patients who've gotten started on progesterone before they had the ultrasound. And so that's a confounding variable in the other direction, because you could see the embryo might be dead already, and we'd be counting that in the denominator and starting treatment, even though not knowing that the embryo is already dead. So the confounding effect could go both ways, to skew the data both ways.
But if the embryo is alive before you give the progesterone treatment, how do you know that it is the progesterone treatment that is keeping the embryo alive?
Well, we only know that, we can only conclude that if we compare to the previous studies that showed a 7 to 20% embryo survival rate in women who did nothing at all. And so, but you're right, in an individual case, in any one embryo, we don't know if that would have been 7 to 20% would have survived, or if the progesterone is causing an effect. But we do know that if we have a 53% success rate right now, that's certainly greater than the 7 to 20% survival rate if you do nothing at all.
Okay, thank you.
Dr. Delgado, that will be the last question, and I want to thank you for your time, and I also want to thank all the students here. And I'm also very inspired by the students, because now we have this novel information, and these students are looking things up and thinking about it and making their own critical analysis and impression of it, and that's what we're here. We're here as a School of Medicine to create lifelong learners, which you are continuing to do. And anyway, I learned a lot today, and I appreciate your time.
Thanks for having me.
Thank you so much, Dr.